So thank you so much, everyone. Welcome to the Division of Continuing Medical Education's Post-COVID-19 Condition webinar series of winter 2025. I want to mention that this is also with the support and with the work done with the Canadian Guidelines for Post-COVID-19 Condition, and all the recommendations that we'll be mentioning are part of this work. So you're aware, and the email and the information will be provided at the end of the presentation. Please note that this webinar will be conducted in English, but slides are in both in official languages, English and French. And you can also turn your own captions by clicking on closed captions and then selecting whether you want in French or in English. So I want to start by acknowledging, as we gather here today, we acknowledge we are on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland of the Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another.
Okay, to start with, we have two quick polls to learn more about who is in the audience and your familiarity with today's topic. The first poll will pop up on your screen now. So please select your role from the list. And I'll give you a little time to read this and just select your answer. Okay, so I can see the majority in this audience are physicians and nurses. We also have patients with post-COVID condition and their family members. We have some allied health professionals, some pharmacists and researchers as well. Okay, so for the second poll, again, this will pop up on your screen here. So please rate your knowledge level about the following post-COVID-19 condition topics before attending this webinar. So you can see A, B, and C. I'll give you a little time to read through these points. And you can just rate your knowledge level. Thank you again for participating. So I can see it's pretty moderate overall. We have an overall moderate to low knowledge level for this webinar. And thank you again for participating. I'll run through the rest of the slides now. So this session is accredited. Following this webinar, you will receive a certificate and evaluation form. The recordings will be available after the series. Please post questions in the anonymous Q&A function or with your name visible in the chat. During the Q&A, you can also raise your hand and unmute. And these are the steps we have taken to mitigate potential sources of bias. I will pass back to Dr. Vasquez to introduce today's speaker.
Thank you so much, Nina. So I have the privilege to working virtually with Dr. Lam. Before, I'm a family doctor, I'm a part of the group working with her, but have the privilege to present today, and thankful as well for her to agree to join us today. But Dr. Lam is an assistant professor. She's an adult respirologist, and she works with the University of Alberta and the Division of Pulmonary Medicine. She's the co-founder and co-director of one of the first post-COVID-19 clinics in Canada. She has published papers on exploring risk factors for long COVID and leads and is involved in numerous local and national long COVID projects funded by industry, local and national grants. Her innovative work earned her recognition as one of the top 40 under 40 by 85 magazine. So without further ado, I will welcome Dr. Lam. Thank you so much for joining us.
Thank you so much for the kind introduction, Andrea. All right, so thank you, everyone, and thank you so much for inviting me for this talk. I'm glad to see that in the poll that it looks like the majority of individuals attending have either moderate or low knowledge in this area. So hopefully over the next 45 minutes, I will be able to augment your knowledge in some way, shape, or form about the topic of respiratory long COVID, what it is, and how can we approach management of this condition. Starting off with my disclosure slide, some of which was already alluded to by Andrea. So in terms of my learning objectives for today, it's really to first identify the impact of respiratory symptoms within post-COVID condition, hereafter referred to as PCC, on patients and their families, describe the appropriate steps for evaluation, diagnosis, management of patients presenting with post-COVID condition, specifically respiratory symptoms, and integrate the CAN-PCC guidelines for PCC into practice of respiratory symptoms and management. And when I allude to the CAN-PCC guidelines, the purpose of this is to just raise the awareness of what has been published and a little bit about how to use that guideline, perhaps integrate that into practice based on what is recommended. I would advise any questions or discussions about the merit or the background of those guidelines and how the recommendations come to be. I would advise targeting that and directing that to the CAN-PCC organization itself, as I was not involved in all of these recommendations, but certainly some of them. So I certainly can't speak on CAN-PCC's behalf. All right, so just kind of to start off, I think it's really important to talk about nomenclature. And before I even start, is just to say, well, let's just make sure that we are all talking about the same thing. And I think this is a really important issue, and not just relating to PCC, but just in other areas of life too. I recently had a conversation with an 8-year-old son of my friend, and he was commenting to me that, a certain situation was skibbity. And I had no idea what skibbity is. I am not of Generation Alpha, obviously. And we launched into a whole conversation about what this means and what it came to be. And interestingly enough, I don't know how many of you have Gen Alpha individuals in your life, but the term skibbity really originally had no inherent meaning. But over time, it's evolved into a slang term used by Generation Alpha to mean either bad, but also cool, depending on the context. So as you can see, I really had no idea what his viewpoints are on this thing that he was telling me about when he said it was skibbity. Like, is it bad? Is it cool? Like, is he telling me that he enjoys it or that he doesn't? And this all highlights this idea of living lexicography, that terms have multiple meanings, or they can have multiple meanings. And in this case of skibbity, it means bad, but also good. And that the meaning can evolve over time. Recall, this term started off having no inherent meaning, but then it took on different meaning based on context. And then as you will see, again, if you have Gen Alpha in your life, that they will have new terms that they start adopting and using around you. And, other terms maybe fall out of use and out of favor. And so when you have this living lexicography, it might lead to humorous situations in your life, in your social setting. But when it comes to medicine, when it comes to research, this actually has a kind of profound implication. Because if we're not speaking the same language or talking about the same thing, then there's going to be discrepancies in what we're looking at, which patient groups we're talking about, and who we want to treat, and whether that treatment is going to be appropriate for that particular individual. Now, when it comes back to long COVID, as many of you know, it has taken on many different names: PASC, PAX, post-acute COVID, post-COVID syndrome, long COVID, generically post-COVID condition, or PCC. And for the purposes of today's talk, and as it pertains to the CAN-PCC guidelines, the definition, the WHO definition, or PCC, is the one that is adopted, and that's the one that I will use for the duration of my presentation. And just to remind everyone, PCC refers to an individual with either a confirmed or probable history of COVID infection based on clinical presentation. And it's usually, symptoms would be usually 3 months from the onset of the infection. And that lasts typically at least for 2 months. And that cannot be explained by an alternative diagnosis. And these symptoms could be so significant that it impact everyday functioning. It is multi-systemic. It may be new onset after recovery, or it's a new onset that has been persistent from that COVID infection. And these symptoms can wax and wane over time. And so the implication of the PCC definition is that pre-existing conditions that were made worse by COVID would not, by WHO, be considered long COVID, i.e., if you had asthma and your asthma is worse after a viral infection like COVID, then those symptoms would not be considered long COVID, but rather asthma. And this will have implications in terms of how we might approach treatment. The other thing with definitions is that while we want to be inclusive and broad, because this is a new and emerging condition, there is no stipulation on the time frame at which new symptom onset after a COVID infection could still be considered long COVID. So in a very sort of dramatic way, example would be if you got COVID at 20 and you developed diabetes at 45 because you have a genetic predisposition, family history, strong family history of diabetes, then technically, if you presented with symptoms and a physician said, yeah, you're very thirsty, you're drinking a ton, you're peeing a ton, that's long COVID. Technically, these definitions could include that. But you can see that there are that might lead to an inappropriate diagnosis. So there are limitations with the unclear implications of these definitions. That is important to keep in mind. So having talked about long COVID, what about respiratory long COVID? Now, this is even more nebulous. Respiratory symptoms, even just starting with the concept of respiratory symptoms. When you think about respiratory symptoms, what do you think of? Well, most commonly, people often would think of shortness of breath or cough or coughing up mucus, having chest tightness or wheeze. But what about other things like chest pain? Is that respiratory and lung related, or is that something else? What about shortness of breath when you're lying down? What about sleep problems? Now, as a respirologist, it is part of my training and my qualification domain that I take care of patients with sleep problems. But also neurologists do as well. So is sleep problems an issue with the lungs, a respiratory issue, or is that a neurologic issue? And if we're defining respiratory long COVID by symptoms, well, what are the list of symptoms that we would say is respiratory long COVID versus cardiac long COVID versus neurologic long COVID? Because there is such a diversity and nebulousness in the definition of respiratory long COVID, when people try to do prevalence estimates or estimates of how common something is, there is a broad range based on what you read. So when it comes to things like shortness of breath, StatsCan cites about a 28% prevalence rate versus 77% in other literature in the Lancet paper versus in UpToDate, that's what UTD stands for, gives an even broader range of 10 to 71%. And then you can see the similar wide range of prevalence estimates in cough, in sputum production, chest pain, and insomnia, 29% versus 1%. That's quite diverse. Brought up this particular systematic review here that in a review of 130 publication, the prevalence estimates of long COVID, and again, they define it as at least 12 weeks in duration, after the COVID infection. It really differed because it also depended on when you ask people they have the symptom. And so the systematic review identified that the prevalence range went from 0% to 93%. So in effect, we don't know, right? 0 to 100%. That's essentially all the possibilities. So as I alluded to, some people define respiratory long COVID just by symptoms. But others might say, well, if you come with this symptom, we got to do some testing to see, well, is it a lung cause? Is it a heart cause? Is it something else? And so another way of defining respiratory long COVID is that these are people with symptoms that could be attributable to the respiratory tract, but they have unremarkable or normal basic tests. And I have them in quotations because what are these tests? Who decided what tests you have to do in order to just say that, yeah, the lungs are fine or the heart is fine. Now, just a little bit aside to talk from the patient perspective, or sort of a more social perspective of what it is that we're talking about. Because on some level, it seems like it's kind of semantics. Like, why does it matter? The patient has the symptoms. I feel short of breath. Surely there's something you can give me to take away my shortness of breath. Like, why does it matter? And I think in my thought to that is, first of all, in medicine, we really try to do no harm. So anything that we try to prescribe, any therapies, comes with its inherent side effects. And it always comes down to a consideration of risk-benefit ratio. If I give you this inhaler, what are your chances of improvement or a benefit versus the potential harm? And that comes from the evidence-based medicine itself to say, well, in a group of X number of patients with this symptom, we gave them this inhaler and X amount of them had side effects, and but a greater number of them had meaningful benefit with use. Well, then that would be a strong argument to prescribing that medication. And so when it comes to long COVID, we lack that evidence right now because the condition is moving at the speed of science. And so we don't have that lead time to do that research before the need. The need is happening right now. And so keeping with the do no harm principle is, of course, to identify things that are alternative diagnosis, which oftentimes have clear evidence of how to manage, i.e., if you have asthma, we have clear guidelines, clear evidence of how to manage that. And if we can make that diagnosis in somebody who had COVID, great, we've got a treatment path. And it's important that I also highlight that I don't think that the understanding is that, well, if I give you an alternative diagnosis, it doesn't mean that long COVID is ruled out. It's entirely possible that you can have an alternative diagnosis in terms of your lung symptoms, but you still can have long COVID. It can be a concurrent diagnosis, but it does mean that the time to getting that long COVID diagnosis could potentially be delayed because we need that time to treat what could potentially be treatable. And so it is in this balance of effects of wanting to do no harm, treating what we can treat before we move on to experimental approaches, that this really is important that we work in a world of patient-centered care. Because the impact of uncertainty is huge on patients and their caregivers. They want to know, what does it look like in being able to return to work, activities, or exercise? Just saw a patient with their partner, and their partner voiced their concern of, hey, like, I'm single parenting our, small child, and, my partner needs time to rest. And, is this life now? And is this what I'm expecting? And so a lot of worries are generated from this unknown. For the patient too, that, is there something seriously wrong with me? What is the future implications? Am I at a higher risk of developing other conditions? So these are all the uncertainty and the concerns that oftentimes my patients and their caregivers relay to me. And so I want to, with that sort of framework in mind, I'll go in the next, 20, 25 minutes or so talking about respiratory long COVID from my perspective as a respirologist. And all the views I'll talk about are my own and based on my experience as a practitioner in long COVID since June of 2020. And then I'll also try to bring in and frame with my thoughts within the CAN-PCC recommendations. And again, not able to kind of speak on the validity or the evidence behind the recommendations, but merely just to allude to them, highlight them as what is out there and how that might be integrated into a clinical approach. So going back to the previous slide that I had shown earlier, starting off with a patient who comes to you or you have that symptom, and then talking about what are the tests that you might want to do or have done in order to rule out alternative diagnoses, and then what to do in the situation when all those tests come back as normal, but the symptoms are still there. Common issues that I would get asked about or see is, first of all, question about post-COVID scarring and post-COVID fibrosis. Is this the same thing as interstitial lung disease, which is a progressive scarring condition, versus post-COVID fibrosis or post-infection scarring, where you had an infection, inflammation drives scarring, but that scar is there forever, but it doesn't continue to grow. A lot of times people have changes in their imaging and chest X-ray or CT, as well as physiologic testing of lung function, PFT, pulmonary function test, abnormalities. Patients might experience worsening of their pre-existing chronic lung disease, such as COPD and asthma, or they might experience new onset of diseases after COVID, like asthma. And then finally, as we alluded to, there is that large group of patients who all the testings are negative, and so they still have the symptoms that is otherwise unexplained. So starting off with post-COVID fibrosis, this is more likely to occur in those that have been hospitalized and in particular who had gone through ICU stay. This is not particularly surprising because scarring is the result of inflammation, and ARDS, or acute respiratory distress syndrome, is a common issue that happens as a result of any infectious or non-infectious causes, which would require intubation. So therefore, those that require ICU care have experienced more inflammation from COVID, and more inflammation leads to more scarring afterwards. Not surprising. The other complication is, of course, iatrogenic harms. So because of positive pressure ventilation that's required to maintain oxygenation or ventilation in the patients, then there could be secondary harms from having been undergoing mechanical ventilation, and therefore there's higher risk of post-intubation fibrosis. Other common complications would include post-COVID clotting. And there's a lot of discussion that have been pointed out that COVID is a pro-thrombogenic event. A lot of autopsy in the early 2000s and 2021 that have demonstrated the evidence of pathologically finding these microclots or clots in general in the autopsy samples. And so our group had looked at provincial level administrative data within the province of Alberta. And we really wanted to estimate the risk of general clots, VTE, specifically, and split that into DVTs, clots in the legs, or PEs, clots in the lungs. And so as you can see, in general, the relative risk after infection acutely is about nearly 5 times in terms of the risk ratio. And generally over time, that risk does come down across the board. And when we split it into both women and in females and males, you can see that general trend of the risk does slowly decline over time as more time has elapsed from the initial infection. In terms of abnormalities in imaging or lung function, it really depends on when you are looking at the patient or assessing the patient, whether you're immediately after or further down the line. So for example, at 4 weeks after, here's one study that looked at a spectrum of individuals, including 67% of them having never required hospitalization. And then 17% of them needed hospitalization, and then 16% of them needed ICU. And as you can see, when they did look at the percentage of people who have changes on their imaging to suggest air trapping, ground glass, small airways inflammation, for those that never required hospitalization is less than those that required hospitalization, which is still less than those that need ICU care, not surprisingly. Now, if you look at 3 months out, and here in this study, they did just focus on those that have the worst inflammation. So they had acute respiratory distress syndrome, ARDS. They needed to be intubated, needed significant amounts of oxygen. And they looked at these individuals at 3 months' time. And as you can see, there is a pretty significant amount of abnormalities in terms of symptoms, as well as a reduction in diffusion capacity and the total lung capacity. And then when there was a meta-analysis by Ginto in 2023, they pulled 47 studies and showed that, at this stage, 3 months post-infection, there's a huge amount of abnormalities that you can still pick up in these individuals. Now, looking at 6 months out now, and again, looking at a smattering of different severities of COVID infection. And at 6 months' time, you can see the percentage of people who have scarring type abnormalities, or the ground glass changes, the small airways inflammation changes, are a lot lower in percentage than what we had seen in this previous slide. For example, the ground glass was nearly 60%. 3 more months had passed. At 6 months' time, this is now down to about 27%. So that is all to say in summary, the spectrum of abnormalities have been described as both obstructive and restrictive changes, but overall, the rates do decline over time. And so when we think back to the question about post-COVID scarring, is this an interstitial lung disease? Certainly the experience so far is that we cannot call this an ILD. Post-COVID scarring, just like any bad infection, leaves some individuals with scar tissue in where that infection had taken place. But at this point, there isn't really evidence to show that it progresses with time, i.e., it's not that burden of scarring will increase year over year as time goes on post-acute COVID infection. Now, of course, if the patient were to go on to get multiple recurrent COVID infections, then of course there'll be more scarring. But that initial scarring itself, it's not proliferative, as you would expect to see in those with interstitial lung disease. In terms of the direct or indirect impact on pre-existing lung disease, I'm just going to highlight a few key examples in my world. So sleep apnea, there's been a lot that's been described that there is a higher incidence of sleep apnea, or OSA. But I think part of that is just due to the fact that we're investigating more at this point, maybe because people are symptomatic. And so there is a high rate of undiagnosed sleep disorder, breathing, especially OSA in this time period. But whether COVID itself drives more sleep apnea, I think that's a question that I don't think it's fully fleshed out. Similarly, in the world of oncology and lung cancers, we're diagnosing more, But again, is this because there's a greater susceptibility to COVID itself, or that we are screening or testing people more, looking at their lungs more because they have shortness of breath? That might be related to long COVID, but we're incidentally finding lesions and abnormalities. That's unclear. There may also have had been an indirect impact from the COVID pandemic itself, where somebody who had symptoms, maybe they were coughing up blood, that during the pandemic they were delayed in seeing their healthcare provider. And so by the time that they are seen, they have more advanced disease. So again, is it that COVID accelerated their disease process, or that it was just an indirect impact of the changes to the medical system as a result of the COVID pandemic? It's a little unclear there. In conditions where it's a little bit more clear, cystic fibrosis, there was several fairly strong studies, registry-based studies that essentially showed that in this subgroup of patients, there actually was an improvement in lung function during the pandemic. And even those that had the COVID infection, they did no worse than the non-CF population. And overall, there were less exacerbations in this patient population during the pandemic. So it seems like this patient group did okay in the time of the pandemic. And then in COPD, we did a lot of work in this area, and certainly a lot of other groups have identified that there were less admissions for acute exacerbation of COPD. But the problem was the mortality for this patient group increased, even independent of COVID infection. So there are certainly direct as well as very real indirect consequences for this group of individuals. The other thing is that when it comes to asthma, there have been reports, and this one is out of Korea, where they identified an increase in incidence rates of asthma after COVID, i.e., they're finding more new diagnoses in the time after a COVID infection compared to a time period before COVID. We've done similar work ourselves, looking at our, again, provincial level data, looking at incidence for asthma. And certainly there is a bit of an increase for new asthma diagnosis. And it's I think this is not clear whether COVID uncovered a underlying susceptibility to asthma, which now we are making more diagnosis of after the COVID infection, or whether we are actually making the right diagnosis that, after a viral infection, maybe you just have more sensitive airways and more likely to have shortness of breath or wheezing. And maybe that's what we're calling asthma, which is not how we should be labeling asthma based on guideline recommendations. So it's not really clear if this is a true phenomenon, but certainly something of concern to me as a respirologist to look for in this patient population. Other work for other disease group of chronic lung disease like interstitial lung disease, we really haven't found any major changes in terms of incidence or prevalence with regards to ILD, regardless of COVID infection. And then now it gets us to that domain of those patients who have unexplained respiratory symptoms, even after investigations, or they don't have pre-existing lung conditions. I think it's really important to also highlight that in these individuals, there are a multimodal level of evidence to say that while their imaging may be normal, their PFT may be normal, research-based advanced imaging, like using Xenon 129, multiple groups around the world in the UK and in Canada have demonstrated that even in these individuals, their shortness of breath seems to be correlated to abnormalities in ventilation, as well as perfusion that they can document in their research based MRI imaging that is not picked up with conventional clinical testing. Those studies from Dr. Parega's lab is reassuring in some ways because they've looked longitudinally, and the patients in her cohort seem to have this improvement over time. And she does find this defect in both that hospitalized and never hospitalized population. And then in another group, in Don Sin's group, at UBC, recently published their findings where they recruited long COVID patients from the long COVID clinic in BC, and they underwent bronchoscopy, so very invasive testing, but very valuable testing that showed us that when you look at the small airways of these individuals compared to those that were having subjective shortness of breath versus those that don't, they can see biochemical evidence of small airways inflammation. And so that is all to say that it is also important for us to keep in mind that our approach is always to find something that we can treat and have an alternative diagnosis, not because we're afraid of long COVID, but that there is something that established treatment pathways that we can go after. But if we don't find that, it is also important to say, well, actually, here's a lot of evidence to show that even though we can't find small airways inflammation on the PFT or on imaging, when you do these different tests or more invasive tests, you can actually find evidence that does correlate between symptoms and small airways inflammation. And so this becomes a rationale later on when I talk about, N of 1 trial of therapy or experimental therapy, off-label treatments. This becomes really relevant to say that, well, even if testing is normal, that still may be the underlying mechanism in these individuals, and therefore it is worth having a discussion with the patients to talk about trying some of these potential therapies that get at reducing inflammation in the small airways. In addition to that, it is also important to understand that unexplained respiratory symptoms can also be due to dysfunctional breathing. So even in absence of finding small airways inflammation, there are many different contributors to feeling subjectively shortness of breath. And that could be due to neurologic contributions, so the sensory centers in the central nervous system that senses oxygen, carbon dioxide, that may have some evidence in the literature for just getting reset, and so they're more sensitive to feeling short of breath. Some individuals have this subtype of hyperventilation. They're breathing faster. Again, thinking that this might be more of a neurologic trigger rather than documented low oxygen or high CO2 triggering increased breathing rate. And so some publications have identified this hyperventilation syndrome or periodic deep sighing in these individuals. Regardless, again, always comes back to the patient that these symptoms really are associated with significant burden for the patients and their care provider, and really impacts their quality of life. And so just to quickly summarize what we've just kind of discussed, particularly those that have had severe COVID, seem to be more susceptible to small airways defects or gas trapping, obstruction, ground glass opacity, and then they have some degree of scarring after the infection, which may rise to the level of a restrictive defect and diffusion or reduction. COVID does clearly confer an increased risk of PEs or pulmonary embolism, but certainly the evidence does seem to show that it goes down over time. COVID, I didn't present it here just because of the audience is quite mixed and broad, but there are sort of more esoteric lung complications, such as organizing pneumonia. So just to know that there are other things that COVID can do to the lungs. We talked about how COVID can worsen in even previously stable chronic lung disease. There may be a signal for increased risk of developing asthma after COVID. And then, of course, that huge subgroup of patients who have unexplained respiratory symptoms, but some of whom can really still have subclinical lung defects, particularly small airways inflammation. So we alluded to this a lot in terms of the workup. Like if you have symptoms, you work them up, and if the workup is negative, then they have, this unexplained respiratory long COVID. But how do you work up? What are the tests that you should do in order to complete the workup? And so I'll talk a little bit about that, but I think it's really important at this point for me to highlight that any workup, any testing that we are doing in the long COVID population must be done in consultation with the patients in an informed manner to balance the risk of provoking harm, post-exertion symptom exacerbation, in context of the value of the workup and whether this is likely to change management or not. So what does the CAN-PCC guideline tell us? Because they have a whole guideline 2, to talk about the workup of PCC. So I'll highlight the ones that are particularly germane to respiratory PCC. So in individuals that have symptoms that could be explainable by a pulmonary cause, first step, rule out whether this is cardiac in nature. And here, based on what has been published by CAN-PCC, there's quite a few tests that they have published on this topic. So they have suggested conditional recommendation for all of these for doing an ECG, doing a troponin I or high sensitivity troponin I, a BNP, as well as Holter monitoring. The next step is to see whether this shortness of breath or these pulmonary symptoms could be at all related to POTS. Now, POTS stands for postural orthostatic tachycardia syndrome. And the CAN-PCC guidelines conditional recommendation is for this 10-minute standing test to assess for whether POTS could be at play. And for those that are less familiar with POTS, this is defined as a sustained heart rate increase of at least 30 beats per minute within 10 minutes of an upright posture. And this has to be in absence of significant changes to the blood pressure, because otherwise this would be orthostatic hypotension. And that clinically these individuals have symptoms that are provoked when upright and rapidly improves when they lie back down. And these symptoms, to the long COVID population can see is certainly overlaps a lot with common PCC symptoms like lightheadedness, heart palpitations, feeling tremulous, generalized weakness, maybe a little tunnel vision, and fatigue. So certainly lots of overlap in symptoms. And these symptoms must be there for at least 3 months, and that there isn't any other conditions that could otherwise explain an elevated heart rate. So, ruling that out, then we want to see whether this could be pulmonary in origin. Now, I was hoping that we would be able to touch upon all these today as well, but unfortunately it's not quite yet published officially by CAN-PCC, but just to whet everyone's appetite, that there will be recommendations forthcoming about the use of PFT, chest x-ray, CT chest, as well as ambulatory oximetry in the role of workup of PCC. So stay tuned for that when it's ready. And then so the sort of last prong of workup of PCC comes from the 4th guideline, which is the neurologic and psych guideline of CAN-PCC. And here there's a lot of controversy when it comes to shortness of breath and mental health and all of that. And what I'll say as a respirologist is that I think of shortness of breath a lot like how our understanding of pain is in this day and age, that there is a biologic reason for pain, an underlying cause for pain. There are societal factors that contribute to the experience of pain. So if somebody who has pain in their legs and they have to walk a lot for their work, obviously their experience and the severity of their pain is going to be worse than somebody who has the luxury or be able to afford not provoking the pain. And then there is a third prong in that sensation of pain that adds on, that is added on based on the psychological contribution. So if somebody who has underlying, mood abnormality, then it's going to make their experience of the biologic cause of pain worse. So that is to say that we're not saying that they're in pain because, their mood is bad. We're saying, well, if their mood is bad because they have an alternative thing going on, that's going to make their experience of their chronic illness worse. And so in order to treat their chronic illness, their chronic pain, we got to address all these three factors. And so in the same fashion, I think of shortness of breath in the same way. And in fact, I've kind of just basically copied and pasted this photograph. Instead of pain, it's shortness of breath. That there is a biologic cause of long COVID or other lung diseases that's contributing to shortness of breath. And if we're not able to help the patients to reduce their triggers for the shortness of breath, they're going to have a greater burden of symptoms of shortness of breath. Then also, if they have an underlying mood disorder, that's going to add to their experience of their very real, very organic cause of shortness of breath. And so as a physician wanting to help a patient with their symptom management, it would be wrong of me to not focus on all three of these domains. And so it's in the spirit that I think the guideline recommends that mental health conditions should not be overlooked, that it shouldn't be disregarded in our multimodality approach to managing symptoms, that there is a biological cause that we should treat. There are social causes that if we can support, for me, in the long COVID clinic, if it's a letter to the employer to say, give work accommodations so that they're triggering their symptoms less. And then in the same way, if there is uncontrolled mental health condition, mood disorder, anxiety, well, that's going to generate more symptoms of shortness of breath or augment their experience and severity of their symptoms. So that shouldn't be forgotten either. So this is, I think, the spirit of what this recommendation is all about. So now we've talked all about the investigations. Well, how do we manage it? Like the bread and butter of it. So this really comes down to the jurisdiction of Guideline 3, which is the treatment. And so there really isn't anything specifically for respiratory PCC, but respiratory PCC, or the symptoms of shortness of breath, is something that can be found in both an organic lung cause of shortness of breath, but also it can be a sequelae of other things going on, like when the patient is crashing from their fatigue or overexertion, that makes shortness of breath worse. And to me, I think in that group where it's associated with fatigue or associated with other symptoms, then treatment of those other things like fatigue will therefore make the shortness of breath better. And so if it's associated with other conditions like fatigue or MCAS, then the treatment should be directed there. And the guideline have supported a couple of recommendations or published a couple of recommendations, one that is related to low-dose naltrexone with regards to fatigue. That is a conditional recommendation against recognizing that there is a forthcoming active randomized controlled trial that is being conducted at UBC to look at efficacy of low-dose naltrexone in long COVID. And that in those individuals with MCAS-like symptoms, and respiratory, and I would say respiratory symptoms part of this syndrome, then trial of antihistamines in this case is a conditional recommendation by CAN-PCC. And just an aside, there's a lot of attention placed on microclots, and maybe that can be contributing to shortness of breath, because certainly COVID does increase the risk of clotting. And so CAN-PCC does say that in absence of a pre-existing clinically established indication for antiplatelet therapy, they certainly do, the recommendation is against, conditional recommendation against. So recall, I had said earlier that even in individuals with clinical tests that are completely normal, they can still have abnormalities identified using more advanced techniques like bronchoscopies or MRI imaging. And so it is from that perspective that I would say that when you get into sort of this off-label approach, how can we do this rationally with as much evidence incorporated as possible? So based on that, this multifaceted level of evidence, basic level evidence of small airways inflammation, I would suggest that trial of short-acting bronchodilators would be reasonable. LAMA therapy has some evidence to help with reducing cough, and then trials of ICS, inhaled corticosteroids, plus a long-acting broncho beta agonist would be reasonable. Ruling out and managing triggers like postnasal drips, so with intranasal steroids, or heartburn with proton pump inhibitors would be helpful. If patients have significant constipation, use of PEG could alleviate some of that shortness of breath as well. Personally, in the right patient population, in a sort of done per protocol, testing like 6-minute walk test might be helpful to help identify patients who drop their oxygen, which is pathologic. And that will lead to a whole new area of investigations of looking what might be going on there. But that's firmly, I would say, in the realm of the respirologist domain to dig into those more esoteric causes. So I won't belabor the point or go into it here. And then recognizing that a lot of individuals end up having dysfunctional breathing, then some resources in terms of guiding the individuals to do breathing retraining. Symptomatically, I think when it comes to things like chest pain, certainly after ruling out cardiac, pulmonary vascular, all of these other PODs, all of these other conditions, then clinical management of symptoms, oftentimes using things like empiric NSAIDs like naproxen would be quite helpful in the right patient population, again, those that don't have contraindications. And then neurologic treatments, if there is a neuroinflammatory phenotype that the patient might have. So things like gabapentin, pregabalin, amitriptyline might be helpful. And then sleep issues, really quickly, oftentimes in the long COVID population, insomnia, frequent awakening, hypersomnia, all of these spectrum of things are quite common. And certainly there have been documentations from sleep study, EEG, showing that sleep is quite fragmented in this patient population. So the basic things is to rule out things that we can treat. We already talked about OSA. Unrecognized OSA is quite prevalent. So definitely have low threshold to send patients for a level 3 or HSAT sleep study to rule out OSA. And then treatment approach would be really start off with sleep hygiene. Many of these resources out there in Canada have great supports for these things. And then trial of pharmacologic interventions like melatonin, magnesium, etc. might be considered. I'll just allude to modafinil. I do see my colleagues using this as a trial. Personally, as a respirologist, we have a very clear rigorous path of when we would diagnose this, which involves specialty testing by us in a sleep center. So I would certainly say before stimulants are used, there are considerations that maybe talking to a respirologist would be good first, or a sleep specialist would be good. So that's really all it is. I know I've gone a little bit long, but this is an evolving journey, and it really is a patient-centered approach that is most important. What I say now might be different a year from now based on more evidence that comes up, but I think that it's important that we are upfront and forthcoming with our patients with regards to our limitations and our willingness to listen and help and support and change based on further evidence and further understanding of the condition. So this is a bit different from our usual approach and how we're trained, but I think that this is particularly important in long COVID. And with that, I thank you all for your attention.
Thank you so much, Dr. Lam. That was a great presentation. As you mentioned, we're a little bit over the time, but I think it was great and a lot of good explanations. There are some comments about the definition and kind of how that may impact the way we approach patients in the chat. And there were a couple of questions. There was a question here from Lorraine Graves. It says studies trying antiplatelet therapy for PCC have shown no benefit, while a study using heparin during and after hospitalization has shown benefit for PCC patients. And since the fibrogen pathway rather than platelets seem to be part of the clotting issues in PCC, are there any recommendations around heparin? Does it help? Does it prevent problems? Is it recommended? And does it hurt?
Thanks for that question. I would not prescribe heparin outside of clinically established indications for treatment. There is a lot of work about a lot of attention paid to microclots and that sort of thing. And I'm certain that there are some individuals, and I've certainly sent some of my patients off to do VQ scans and things like that to look for chronic clots. But in absence of finding the evidence of that, there is certainly a lot of harm that could happen with anticoagulation inappropriately, such as brain bleeds, GI bleeds that can cause a lot more harm in a situation where we don't have any evidence of benefit.
Thank you so much for that. There's one question from Sylvie. It says, I have a subgroup of patients in which the respiratory symptoms are the main symptoms that improve significantly to almost normal with azithromycin when they reach the point they score for bronchitis or pneumonia treatment. Did you observe this in your practice, and how do you treat them?
So I think is the question referring to those that are on high dose like regular dose azithromycin for treatment of pneumonia bronchitis versus chronic low dose azithromycin as an anti-inflammatory that is used in conditions like COPD or non-CF bronchiectasis?
Yes, it's regular dose azithromycin, but I wonder if they would have benefits if they were put on chronic azithromycin, since they improve when they have treated, but they relapse when we stop the azithromycin, like 2 weeks after they relapse. So thank you for answering my question.
Yeah, okay. Yeah, thanks for that, Sylvie. I don't often give azithromycin, but that's only because of a specialist bias, because by the time that I'm seeing the patients in my practice, they're sort of more complex. And so by, IDSA CAP guidelines, I wouldn't be giving azithromycin in those cases. So I don't know for acute treatment, but certainly I think your thought about possibility of trying low dose azithromycin is reasonable, given the fact that, again, there is evidence of small airways inflammation. Low dose azithromycin is not acting as a antibacterial, but rather an anti-inflammatory. So certainly I think the biologic rationale is there. I just don't have that experience in this patient population, and certainly sounds like a very plausible thing to try, particularly in the groups of patients that have this symptomatic benefit. But I would also say that in doing, chronic low dose azithromycin, Safety first being, check things like QTC, because it's a QTC prolonging agents. And I would also recommend doing a sputum culture beforehand, just to make sure that there is no NTM colonization, because if these individuals end up needing to be on MAC therapy later on down the line, then they may become resistant to azithromycin. So those would be the things that I would do as kind of safety whenever I start anybody on chronic low dose azithromycin.
Thank you so much for that clarification. And is asking whether or not there is a study going under using azithromycin that you know of. Is there any study going on right now? Okay.
I don't know. Certainly not in Canada, but I haven't looked at the clinicaltrials.gov website. That would be the best place to search azithromycin and long COVID for clinical trials. It's a great idea. I really like it.
Good. Well, thank you so much. I think just for a matter of time, we will return, but I want to ask you, Dr. Lam, if patients or participants have more questions, will they be able to email or contact you in any way, or maybe?
Yeah, absolutely. Feel free to reach out to me. My email's really easy. It's just glam@ualberta.ca. I didn't pick it. But yeah, it's just glam@ualberta.ca. So I'm happy to answer any questions. And sorry, I went a little over time. There's a lot to talk about in this area.
Currently, no, I agree. It was a great overview. So thank you so much. Your email address is posted in the chat for those who may have further questions. Thank you for that. So I want to thank everyone for attending. Please complete our survey by scanning this QR code above that you're seeing here and clicking on the link in the chat box as well. Please stay up to date. Go to the the CAN-PCC.ca website for more information about the national guidelines. Check out the CAN-PCC recommendations map. And please scan this QR code to sign up for the CAN-PCC newsletter if you want to receive more news about that. And about the post-COVID-19 condition webinar series, please explore more PCC webinars by also scanning this QR code. Stay up to date in the knowledge about that by registering by the upcoming webinars in the series. And you can also access the webinar recordings if you miss the session, or you want to actually go over that to get more highlights about the webinars in our website with the Continuing Medical Education PCC website. And we can let you know that those are going to be posted once the translation of the captions into French are available. So they will be available for both English and French. Thank you so much again for your participation. Thank you, Dr. Lam. It was great.
Thank you so much for including me.